So next up is Videha Sharma. Videha works as part of our team in the Northwest and has been leading a programme of clopidogrel pharmacogenetics around stroke. So,
Thank you very much, Bill. Good afternoon, everyone. Very great to be here. Great to see lots of familiar faces, but also lots of new faces, which is really, really good. I really enjoyed your presentation, Wout. I thought that was fantastic. We're going to stay on the same topic, probably from a different angle, but hopefully lots of shared learning. I'd be keen to get your thoughts on some of this stuff as well. Just have to switch the... Perfect. Awesome. Cool. So this is meant to be a workshop or more of a group discussion type session. Of course, that's really difficult with such a large group. I'm very, very grateful that so many people come, but that's going to make it obviously a little bit more challenging. For that reason, I've got a few questions. They're going to be coming up on the screen in a little bit. I'm going to do a bit of background, a bit of introduction first, but it'll be great to get as many of you involved answering some questions on a Slido. So you'll need your phone or your laptop if you're using that to contribute to that. It's not often we have a room full of people that are enthusiastic as well as experts in PGX, so it would be a really great opportunity to get as many people voting on the different questions and helping us to try to understand some of the challenges around implementation. So as Bill said, I've been asked to lead a piece of work around how do we implement genetic testing to guide the prescribing of clopidogrel in the NHS. And that's, of course, a large and complicated project. It's not like implementing a genetic test in a single hospital. This is trying to think about an entire healthcare system at a national level. So there are significant additional complexities that come with that. And hopefully, you're going to help me think through some of those complexities. As many of you who may have heard me speak before, I'm always very, very keen for feedback and criticism. Don't feel shy if you think that whatever I'm saying is wrong or I'm stupid. Feel free. You can tell me to go back and be a transplant surgeon again because that's a lot easier than trying to do this. Just please let me know. Please do not hold back. Cool. So I'll give you a little bit of background and introduce what we've been tasked to do and a little bit about our approach because we think we're taking maybe a slightly different approach to perhaps implementation in the past, certainly in terms of our ways of thinking. Then we'll spend quite a bit of time talking about some of the challenges, and as I said, there's going to be a few questions. And what we'll probably do is we'll do the questions, see what kind of people are polling, what people are responding as, and then we'll maybe stop at each question. There's only 3 to maybe have a bit of a discussion, or we can have a discussion at the end and throughout. So pretty informal. So as you all, of course, already know, and Wout is in far greater detail and in far more greater elegance and described to you the scientific background around the reason for doing CYP2C19 genotyping to guide the prescribing of clopidogrel. Within the stroke community, within the doctors that are going to be tasked to do this, and we're going to come back to that in a moment as well, this is often described as clopidogrel resistance. So folks don't talk on the ward or on the clinical front line about poor metabolizers or loss of function, etc. The term that I've heard most frequently that people say is like, oh yeah, clopidogrel resistance. Oh yeah, we do clopidogrel resistance testing. Oh yeah, that's a great idea. So that's just another way of describing what I think is the same thing. In reality, we of course don't do this in routine practice at present, certainly not at scale. There have been various little pilots and individual centres have had little bits of experience, but this is not something that is available at present across scale, across the NHS. But of course, it's very important. There's a huge opportunity to improve care and outcomes as well as reduce costs based on some of the numbers. So you'll all be familiar with this nice guidance that came out only a few months ago, which says or recommends that all patients admitted to hospital with a stroke or TIA should receive a CYP2C19 genotype test to guide clopidogrel use. This is a step change, I think, for pharmacogenetics. We're, of course, all very enthusiastic, and we want this to be part of healthcare. But having nice guidance, I think, is a significant change, particularly as we're trying to influence people outside of our community to recognize the importance of this. So the question that we've then asked ourselves, very high level, initially the question that we asked ourselves is, okay, well, how does the NHS implement this nice guidance into, and as a diagnostic service, into everyday care? And how do we make this from a piece of document, a piece of paper, to a moving mechanism, machinery that's working across an entire country, across lots of different healthcare providers. But actually, when you think about this a little bit more and try to think about this maybe perhaps from a more holistic perspective, really what we should be thinking about, I would argue, is not just how do we implement this policy, but how do we ensure that patients with a stroke or TIA receive the right treatment? That's really what we're trying to do. And that, I think, abstracts slightly from purely focusing on the guidance and what it recommends and thinking more about, okay, well, what does the real world look like? How do hospitals work? How do doctors work? How do people think? How do they communicate? What are logistics like? So this is like a little bit more of a real world way of thinking about, I think, what we're trying to achieve at scale. I'm not going to spend too long on this. This is also perhaps slightly small, but this is really quickly to give you a bit of an overview, a schematic overview of what a typical stroke pathway or a TIA pathway looks like. And this is really just to highlight, first of all, the acute nature of it. So this is acute care, which is different to perhaps other types of genetics or more traditional genetics where there is perhaps less urgency in terms of having results. So patients come in, they are rapidly assessed. Stroke services in this country are centralized. So all patients within a particular region will go to what's called a hyperacute stroke unit. So as that term, hyperacute, it sounds pretty scary. I don't know if I want to go there. But as that name suggests, it obviously means that it's for really, really urgent things. At the same time, that means because that's centralized, resources there are limited. So patients will be there for a short period of time. The typical average length of stay in a hyperacute stroke unit is 2 to 3 days, after which the patients will be referred back once they've been stabilized to their local hospital, or indeed, if they've recovered, they might even go home. So this is a quick turnaround clinical service from a hyperacute stroke unit perspective. From a clopidogrel prescribing perspective, the most common scenario that folks have described to us so far and what the stroke guidelines suggest is aspirin initially for 2 weeks and then switching them to clopidogrel after 2 weeks. That's the most common model that we've heard of. There's already local variation that we've seen. There's already places that start with clopidogrel from the outset, which is of course different. That means that there isn't that potential 2-week window of receiving aspirin. People are on clopidogrel at the outset, so in theory you would want to have that genotyped guided result there and then to be able to prescribe that index prescription. For TIA, things are perhaps even a bit more complicated because patients that have a suspected TIA, I think it's a great service. You go to A&E or you go to a general practitioner and then you can be booked into a TIA clinic to be seen within 48 hours. So you may have had an episode where, I don't know why I'm saying you guys, someone may have had an episode where their arm stopped working for a little period of time and they went to the GP and the GP said, gosh, could have been a mini stroke. I'll send you to the TIA clinic and you could be seen within a day or two, which is really, really quick. Now, if a TIA is clinically confirmed, those patients start on clopidogrel there and then. So again, there is a real acute nature there in terms of that result being available. Cool. So as we've then tried to think a little bit more broadly about a pathway, as I showed you that pathway a moment ago, we've tried to take a step back and say, okay, well, what are the different bits of that pathway? What are the different bits of that process that we need to think about if we're trying to design a survey? So there's something around patient selection. There's something about which of the patients that we should be doing this to. Is it all patients? Should there be a phased implementation? Is it high-risk patients? Is it patients from certain ages, demographics, etc.? Is there something that we need to think about there? How does this work how do physically samples get taken? Who takes it? Who fills in the request form? What does that request form look like? Is that paper? Is that electronic? Whose responsibility is it? There's lots of, on the surface, it sounds great implementing a new diagnostic service. When you get onto the granular level and onto these details, and when you get onto the clinical shop floor, and I'll share a little bit more about that in a moment, you start to realize, gosh, there's actually quite a lot of complexity here, and there's quite a lot of different people involved, and there's quite a lot of process and operations to get right. Similarly, when a test may have been performed, how are those results received, whose responsibility is to receive those, whose responsibility is to action those and communicate those to patients. And indeed, there is the whole challenge around if the patient indeed has already left the hyperacute stroke unit, who and how do we find that patient again to inform the clinician who's now responsible for them about this result? I mean, you might all think it's really easy, and if it is, then please come and tell me how to fix this. But I'm struggling so far. So the approach that we've set out is borrowed from perhaps a more kind of tech way of working, or more design way of working, where we've said, well, gosh, this is complex. This is hard. There are multiple stakeholders, there are multiple organizations, there are loads of moving parts. We're not going to design or implement the perfect service from the start, but we have to start somewhere. And the phrase that people will maybe be familiar with is minimal viable product, or MVP, and we've taken that approach and called it a minimal viable service, or maybe even a minimal viable scalable service is what we should be thinking about. And that really involves with working with those people that are going to be delivering the service, as well as those who will be using the service, the healthcare professionals and the patients, to design how this is going to work together with them. Starting small, so we're working with 4 pilot sites across England. That's St George's, where we visited yesterday, Doncaster, Exeter, and Salford. And the idea is to provide them with some support. So myself and a service designer will be visiting all the sites. We've been having workshops with them and helping them think through exactly how does this work. Similarly, on the testing side and laboratory side, we're working with the lab and different clinical leaders of the lab about how what their requirements are and how we can think about integrating those two disparate parts of the healthcare system. Ultimately, our aim would be to produce an implementation guide or some documentation that we can then share with other stroke centres that hopefully will allow them to be able to pick up all the learnings that we've had during this pilot process and put that into practice. Now, I said to you earlier I would come back to the point about stroke doctors, and Jess, I think, did this earlier in her workshop. Does anybody here work in stroke care? So I think perhaps a little bit similar to Jess's experience in the cancer workshop, we are, again, similarly very enthusiastic about this, very passionate about this. We want this to happen. We're excited about the NICE guidance. But we are not the people that are going to be delivering the service. None of us see stroke patients. None of us go onto stroke wards. None of us prescribe medicines for stroke patients. So there is a real gap, I suppose, there, which is why we think this approach, and that's the feedback that we've had so far. The stroke centres have been very enthusiastic about this because we are physically going to them. I went to St George's yesterday. I'm going to Exeter tomorrow. We're physically going to them with all of this information and spending time with them, helping them to put this into practice. And they've been so far very, very positive, enthusiastic about that. So I'm going to stop talking in a moment and start to try to get you involved a little bit more. But just to give you an overview of the project. So we've just kicked off a few weeks ago officially. It's led out of the Network of Excellence and supported by the Stroke Programme and the Genomics Unit. As I said, we've got 4 pilot sites and we're providing them with some support. We went to St George's yesterday, and you immediately realise when you get onto that clinical shop floor, when you get onto the ward and you walk around and you speak to the different staff, and that's where you start to realise that gap, I suppose, with where perhaps a guideline may be, or where a policy or a concept might be, and what is actually happening on the clinical front line. And how do we help them? Somebody said, I don't know whether I should say this, but somebody said yesterday, this will be fine. It'll be a nightmare, but it'll be fine. How do we make this less of a nightmare for them, right? How do we support them that it isn't, ideally, that it isn't a nightmare, that they're actually like, wow, we're actually delivering personalized care for patients. We're actually improving the effectiveness of the medicines, and hopefully they're not going to come back to hospital with another stroke as a result of what we're doing. So that's the message, that's the work that we have to do. We hope to have outputs by springtime next year, and importantly, the costs of the testing are covered as part of this project. So the reason I say that's important is I think that's one of the questions and perhaps one of the topics for debate very shortly. And Wout, you've already been struggling with that question as well. So we'll see if we can share some of our UK experiences. This is just a picture from yesterday. This is a junior doctor on the ward with the request form that they were trying to fill in. As you can imagine, as you can see, they haven't filled in anything. They said that the top bit, the name, the NHS number, that I could do that. but then I'd have to ask for help for everything else. So, being able to get that real world frontline clinical feedback is really, really important, because then we can think about, okay, well, either education do we need to put in place so people can fill out these forms, or is there anything that we can do to change these forms to make them more usable by the people that are actually going to be using them. So just to give you some food for thought before we kind of go into some questions and discussion. This is very exciting. Like, I am super excited about this, because I think this is going to really change how we deliver care, and it's a great first step, especially if you start to think about this is personalized medicine at scale. But it's complicated, it's hard. It's a new diagnostic service that's going to be used by people who know nothing about genetics, who maybe heard about genetics in medical school or nursing school or pharmacy school, but are not using that as part of their daily work, so they're completely unfamiliar with it. It's not research, so we are not, we don't have any research funding or grants or anything like that. Additionally, we don't have some of the additional support that comes with research projects, like a research nurse or someone who can, go to a site, or additional resources that could help with that. We're very much expecting or hoping or relying on the goodwill of these sites, currently the pilot sites, who perhaps are getting extra attention, but ultimately we're going to be relying on the rest of the NHS to do this, on top of already everything that they're doing, right? So I think our role is to try to make that as easy as possible, so that, and facilitate that in a way that induces the minimum amount of burden. From a scale and turnaround time perspective, this is, again, unprecedented. This is acute, so we need, in theory, that information needs to be the clinical frontline far quicker, and as a result, there's going to be significant logistical and operational challenges, and we'll kind of get to the different approaches, from kind of centralized laboratory testing versus point-of-care testing. Of course, we have to remember, and I'm sure it'll be the same in the Netherlands, not every hospital will have a genetic laboratory on site. In fact, many of you will be aware, in England, of course, we have 7 genomic laboratory hubs at the present. One of them is doing all the pharmacogenetic testing for the pilot, and there are decisions and questions about how does that work if we try to scale it? Does it work if there is one single site that's serving the whole country for a potentially acute genetic test? So lots of unknowns, lots of questions still to answer, including about guidelines, alternative prescribing. People will have different, opinions about what they want to prescribe and what they think is a better alternative. We also don't have any real connected infrastructure at present, particularly digital. So it's not like you can sit in hospital A and order a test in a different laboratory. So for the pilot, we are doing this entirely paper-based, and we're doing that purposely because we do not have capacity or funding to try to think of digital solutions. But that, of course, is potentially a barrier to scalable implementation. And then the one at the bottom is just kind of there hiding, but it's actually probably one of the really big ones. Who pays for this going forward? So that'd be something great to kind of think about. Okay, I'm going to stop talking. I've flown through a lot there. I hope I haven't given anyone a headache. But I'd love to ask you to think about this question to start with. This is a ranking question. So, I've got no idea what's going to happen here. If you've got your phone, you should be able to scan that. You might have to zoom in. If not, you can go to slido.com and put in that number as well. Hopefully that's working, and it's a ranking thing, so I think you have to choose all of them, because they're all challenges, so I don't want you to have to choose one. They want to make it easy for you. So very good, numbers are going up. Here we go. Something's trying to come in, okay. Oh, hello. That's great. Thanks so much. You're doing really well. It's a bit like a race, isn't it? You can place your bets if you want. I'm going to give you another minute or so. And also, whilst you're doing that or looking at that, do have a think about if you've got any thoughts or anything you'd like to share from your own perspective, or from your own background about this topic, about where you think the key challenges are. I appreciate it. Not everybody will be comfortable speaking in such a big room, and that's absolutely fine. But But if you do, then I'm very happy for people to put up their hand in a minute and shout abuse at me. Cool. Wow, we've got 65 people that have ranked. Still a couple maybe to go. Makes sense that money's number one. Yeah, I agree with that. That's amazing. So thank you everyone for voting. That's 70 people. I mean, that's a lot. That's really, really good. So thank you so much for that. Any thoughts or anything that anybody would like to feedback based on your own thoughts? Jude, thank you.
You just asked a question. Sorry, thank you, Kim. Hi, I'm Jude, GP, Innovation Director for the North West GMSA as well. I know you asked the question, are there any stroke physicians in the room? I mean, in primary care, we're anticipating that we are going to be directly impacted by this. And in primary care, the way that we work is if anything is integrated digitally in data, then the clinician awareness follows. So actually, that's a sort of prerequisite, really, towards making people aware.
Okay, great. So what you're saying is that digital. So you think the digital integration bit is important. Okay, cool. Yeah, there's a question right at the back there, or a comment at the back.
Thanks for a great presentation. I was just wondering, when you're visiting your sites, are you involving different teams? So as well as the acute stroke service, are you inviting clinical pharmacy, clinical pharmacologists and other members of the healthcare professional community within that hospital to come to your meetings so that they're all aware as you roll this out?
Yeah, so we've been led by the pilot sites, really, who they think particularly are important. We've given them a little shortlist, which includes, as you said, the doctors, the stroke nurses, the pharmacists. So most stroke wards will have a pharmacist. So that's who we spent most time with yesterday, in fact. We've not met with a clinical pharmacologist specifically so far, or they've not been involved in the emails as far as I can remember. But they are, I think, the core kind of clinical delivery folks we've spoken to. And then the other additional support that we've received, and all of this is, all of this is new, right? So we're all kind of trying to learn and figure out as we're going along. And there are, just like there are 7 genomic laboratories, each genomic laboratory region also has a GMSA like we do, and we are the Network of Excellence Pharmacogenomics. There's similar GMSAs in all the different regions, and folks from the GMSAs have been very open to provide their support as well. So yes, at St George's, colleagues from the GMSA locally came, and they're providing additional support, as well as some other genetics kind of people. But not any clinical pharmacologists. If you think that we should involve them, then I'm very happy to hear that.
I think certainly, I don't know about Exeter, but definitely at St George's, they may already be on your team, but there's lots of clinical pharmacologists who are very interested in pharmacogenomics, and I think they could add strength to your project if they're not already involved.
Cool. Thank you so much. Great. There's another question here.
How did you select your sites? How did you decide that was where you were going to pilot this? Do I need this?
So how do we decide where to pilot this? Yeah, really good question. So we wanted to have a geographical spread. We wanted to have a diversity in terms of sizes of units, so not just large teaching hospitals or academic centres. We wanted to make sure that there is a breadth of size as well. And we wanted that the populations that they serve are diverse. So Exeter and Doncaster might be perhaps more rural or less urban areas. And then St George's, of course, a large urban teaching hospital, which serves a very diverse population group. So that was very important for us. And similarly, Salford, again, a large teaching hospital which serves not just a diverse population group from a heritage perspective, but also from a low socioeconomic background perspective. So those are the priorities when we were selecting pilot sites.
Thank you.
Great. It's a question here, there, and then Wout, and we'll move on to the next question because I've got a couple more. Oh, sorry. Sorry, I didn't see you.
I don't do acute medicine anymore. I stopped doing that a few years ago, so I don't see patients acutely, but I do see them in my clinic.
Yeah.
because I had blood pressure clinic, so they come in after stroke and then they're found to have hypertension, etc. It seems to me that stroke teams have introduced lots of different things, mostly paperwork, tools and so on, which I'm not sure what the evidence base is for those tools. But it seems to be driven by champions to be able to introduce this kind of assessment. So unless you have champions in those particular stroke units, now in the 4 you may have those champions because it's self-selected in a way. But overall, wider, you will really need to have champions to really push this through.
Yeah, I completely agree. And Bout, you said something similar around if you want something to be implemented, you need enthusiastic cardiologists, neurologists, etc. So you're absolutely right. I think that's really, really important.
Hi. My question is, how much does impact the normal procedure they used to have before? And how much does the introduction of the pharmacogenetic impact those procedures? Because I have learned in our experience that we didn't respect the normal procedure they had at the clinic, that was a problem because there was always someone who didn't work it, and then it was very important to continue that, and then very small changes, but that's how do you consider that? Thank you.
Yeah, absolutely. So that is central to our whole strategy. That's the whole strategy around having a minimally viable approach. So we're taking, really small steps. We're taking time as well. We're not saying testing starts tomorrow. We're taking time to work together with them to see how it will, because it is going to impact the standard clinical practice. It is not invisible. It is going to be different work, not necessarily more work. So how can we think about, are there already existing blood-taking services? All patients have bloods in the morning, phlebotomy comes around, okay, can they do the blood sampling? The result comes back, can it come back digitally? Well, it can't, okay, can it go to an administrative person who can then upload it onto the electronic health record? Okay, taking a little bit of complexity away there. So absolutely, these are the things that we have to work with those guys to solve, but you're absolutely right. Like, this cannot be something that we say, oh, you have to do it like this, because then it will just not work. It will not get adopted. And what I'll do is, I know there's more questions. I'm going to move on to the next thingamabobby, and then we'll pause again. So, and the next one is kind of related to this. So, you'll have a chance to get involved and do some more arguing. So now we're going to flip it a little bit. It should, if you were logged in before, it should just have moved on your screen to the next one, by the way, sorry. So you shouldn't have to scan again. So this is then thinking about, okay, so we've talked about the challenges. Well, what should we then try to prioritize as we collectively, as a healthcare system, as a community, want to think about implementation? So what should we be putting as at the top of the list in terms of where we put our time, money, resources, etc. into, which might be different to what the key challenges are as well. So that's the whole point of this. See if we can get as close to 70 as before. That was very good. I was very impressed with that. Cool, amazing. I think we're pretty much there. Okay. Cool. Any further thoughts? So now we've talked a little about, okay, we've talked about what the challenges are, but where do we need to be putting our effort? So it sounds like, I should stand here, shouldn't I? It looks like the lab infrastructure is maybe something that people, not necessarily lab, but kind of equipment and staff that can kind of do the testing is something that folks think is really important, as well as training frontline staff. It seems to be perhaps more something we should be focusing on than that digital data integration, standardizing prescribing guidance or guidelines for that. Interesting to see. I mean, I'm kind of in some ways glad to see that the build for the clinical evidence is not that high at the top, which I think, again, chimes with obviously the conversations that we've been having. Obviously, we are a biased group, so it's no surprise that we kind of think that, but that's reassuring in some ways. Did anybody, there were some hands up before. Bout, do you want to come in and then we'll go?
Yeah, I want to go further on that, like point 6, build further clinical evidence. It's very striking that it's that low, also in the previous question, because I'm very convinced that you should genotype also in these patients in neurology, but there's the clinical evidence for that strategy is quite low, especially if you compare it within cardiology.
Yeah.
So there are few trials who've done this in neurology. You have one big Chance 2 trial from China, but that's with ticagrelor. I don't know if you used that as another option. So I would think if you implement this, you should also register everything you do and provide evidence that it's working and that it's better. Like maybe compare it like we did, is also to register it and share the results so that in clinical practice and it does work. So I think that should also be it's also vital for the implementation, also at the beginning. Yeah.
Cool. Thank you very much. Is there a question here? Thank you.
From the cancer session, it was very clear. It's not very clear who is going to actually prescribe a test like this. So I think one of your challenges, which doesn't come back here, is ownership of who's actually in charge of this.
So I think it's pretty clear who's in charge. So it's the stroke doctor that's in charge of this.
So they ask for the test?
They offer the test. They are delivering the service. They're doing the prescribing. So don't get me wrong, people might not agree, but I think that is who's responsible. It's a specialist test to guide something in their clinical practice for a medicine that they prescribe, which is also important because, again, some of the early conversations have been, and that's kind of the next question, is around, okay, so the patient's been discharged, say after day 3 or day 4, the result comes back after 5 days or 6 days. What do you do there? How do you find it? Okay, oh, fine, we'll just write to the GP and the GP can do this. Or, well, I think that's not right. This is a specialist test ordered in a specialist setting. Even the acute, the stroke doctors might not have the right level of education or awareness, but our GP colleagues are perhaps even further away from prescribing genotype-guided prescribing in stroke. So to expect that that's something that's handed over to another clinical team, I don't think is appropriate. So I think this very much sits in stroke. But you're right. They might have a different opinion on this. They might say this is a genetics job. Geneticists should be doing this, or clinical pharmacologists should be doing this. Yeah, sure. Yeah. Sure. It's the stroke team is what I mean. They take responsibility and they need to figure out amongst themselves, is it the doctor that gets the result, or is it the nurse, etc. Absolutely. Is it part of the order set when the patient comes in that you just click one, you have the blood pressure, the cholesterol, etc., and you have the genotyping test as well. So I think there was just a question that you've been waiting patiently. Thank you.
No, I just wanted to ask it. It's lean on from your last question. So after discharge, what happens to that test? So if you're a patient that's been tested in one of the pilot sites, but then you get poorly again, you end up in a hospital in a different region, and then someone's reviewing your medications, how do they know that's happened?
Very good. That is the next question that we're going to tackle in just a minute. So hold that thought. But absolutely, that is something that I do not know the answer to, and you guys are going to help me in a minute. Jess?
Yeah, I was just thinking about looking at standardizing prescribing guidance being relatively low on the priority list, and thinking about what is really being meant by training of frontline staff and what is it that we're training them to do. So if it's training that everyone needs a test, sure, and otherwise no one requests a test. But if there isn't guidance, then people don't really want to be trained on something they don't know what to do with. So I feel like the guidance maybe needs to be further higher up. And similarly with data and digital solutions, what is it we're returning to people? I thought, Vout's screenshot of there's a digital solution, but it tells you based on guidance what you're supposed to do. So I was just interested to see the relative ranking of those.
Yeah.
It's fascinating.
Cool. We're going to go to the next question, and then we'll also make sure we include your comment if that's okay. So, just as you said, should we reuse this data? In other words, a patient's had a test as part of the pilot, and we've returned that currently in a really manual, static way. And we're returning that because there's nice guidance for genotype-guided prescribing in stroke. There isn't nice guidance for genotype-guided prescribing of antidepressants at the moment, or other, primary care prescribing. But on the other hand, you might say, well, there is lots of clinical evidence, like we said, perhaps in other clinical indications. I don't know if I want to see this. Okay. Yeah, fair enough. Okay, pretty clear. I'm not sure if every the kind of policymakers, the insurers, and the kind of decision makers would agree with that, but I think that is pretty resounding. Okay, that is super helpful. I love it.
No, you can't do that. You can't pull the person out. Unless it was you, Minute.
I love that. Did you want to come in? No? Did you want to come in at the back? Sorry, I know you were waiting for a question before. I feel like there's not much to talk about.
It was just related to the lady's question about how the data is shared if the test has been done elsewhere. One thing we haven't talked about is more and more people are doing private tests, genetic tests privately. And so they may already know if they have poor metabolism of clopidogrel. And I actually do know that I am a poor metabolizer. And this whole conversation has made me think that I need to be sharing that data. If I was to present in an acute setting, even if I did share that data with my GP, and I haven't done, and I'm going to after today, is that information accessible? Because the test has already been done, it's been paid for, the data's there. So I think more and more people are going to be doing these kinds of tests privately, and so the work's already been done. Half the work's already been done there. So I just think it's another point to incorporate. Thank you.
Yeah, no, thank you for sharing that. You're absolutely right, and I think it's we kind of frequently talk about this. We clearly are also enthusiastic about this, but there's also patients out there that think this is important, and potentially, as Viv highlighted earlier, they are potentially a great advocate for us to try to shift the needle and try to promote implementation. At present, if you were to share this with your GP, which, as you say, you certainly should do, in terms of, is that data going to be available across the healthcare system? Well, no. We don't have any kind of strict structured digital data infrastructure that would make that data available across the healthcare system, certainly not in an alert type, helping people prescribe type of way. Perhaps as like a static piece of paper, like a digital piece of paper, like a PDF report that maybe could be shared, but even that is potentially not really in place at present. So lots of work for us to do. Jude, do you have a question? Yeah. And then we have time.
Apologies, Videha. It's not really a question. It's just a reflection in response to the last comment, really. I think if that information pitched up to a generalised workforce GP at the moment, they wouldn't know what to do with it. So there are a couple of work streams that are ongoing at the moment trying to support primary care in these sorts of situations. One is looking at updating our current position statement around use of commercial testing information when it presents to general practice. And the other is that we're doing some thinking in the network of excellence around the broader implications for prescribing in general practice, because of course we are prescribing these other, not just general practice, but in polypharmacy we're prescribing these other medications as well. So I really absolutely take on board your sentiment, but if we could just hold back until we've got the necessary information to support our primary care colleagues, that would be fabulous.
Great. Well, thank you, everyone. I'm going to stop here because I want to give Lucy time for her talk as well. But thank you so much. That was really, really, really helpful. Last QR code, I promise. We're running a webinar. Okay, that's gone. We're running a webinar at the beginning of November as well on this topic. So if you'd like to know more about that, then please feel free to either scan that, but obviously just look out for it. Feel free to email us or reach out, and we'll share the link, the registration link. But yeah, we can leave it up just for a second whilst Lucy walks up. Thank you so much.
Videha, thank you so much. As always, just full of energy, thought-provoking, and really valuable, and great to get some of those responses and to hear what people are thinking more broadly. Right, absolutely great now just to move on to invite Lucy Galloway, who's a consultant pharmacist working in the area of pharmacogenetics, to talk a little bit about developing this open access around pharmacogenetics as a reference source, which is really important that we invest some time and energy into thinking about this. So, Lucy, thank you.
Thank you. Hi, I'm Lucy Galloway. Thank you for the introduction. I'm here today on behalf of an organisation called the UK Clinical Pharmacy Association. And I want to share with you a project that we have just started to develop an open access pharmacogenomics reference source for the UK. So just to sort of introduce to those of you who are not familiar with the UK CPA, we are a membership organisation for pharmacists and pharmacy staff working in clinical practice. The organisation is a not-for-profit organisation. All of its monies comes from memberships and educational events, and all of that surplus is reinvested into the association to provide member benefits and support initiatives to improve patient care. UK CPA aims to provide education for pharmacists and pharmacy staff. We also have communities of practice to provide mentorship and a sort of clinical advice. And we also promote ourselves as being part of leadership and influence in the practice of pharmacy. We are quite a big organisation. We have around 3,000 members and 17 communities of clinical practice, one of which is a genomics community, which was established 2 years ago. So in terms of our handbook of pharmacogenomics, what is our aim with this project? Well, our aim is to provide a one-stop, open-access pharmacogenomics reference source for healthcare professionals in the UK. Because we think that there is a gap and that this is very much needed, although there is a suite of resources available, we think that we can offer something unique. So this handbook aims to reduce the need for individual organisations to devise their own guidelines and hopefully reduce elements of risk and confusion across different treatment settings. So we've talked a little bit today about how people who are perhaps not experts might be able to access information on what they do with pharmacogenomic results. UK CPA is fully funding the project, but it will be managed by volunteer pharmacogenomics experts. So why do we think it's needed? Well, everybody in this room will be aware that the UK is now at a tipping point for introducing pharmacogenomic testing into routine practice. We've talked about some of the areas in which that's about to happen. And we know that there are a range of resources available at the moment, but they're on lots of different platforms and they're in lots of different formats. And most of the resources that are available are actually not aimed at a non-expert audience or are perhaps not that user-friendly. And although there's quite a few international resources, they don't always map exactly to UK-specific guidelines or, quite importantly, UK product licenses or marketing authorisations. On this slide, I've sort of shown what I think the sort of existing resources are, and I don't want to downplay the value of these resources because they're absolutely amazing resources. Certainly organisations like CPIC and PharmGKB have done all of the heavy lifting for us. These are peer-reviewed, evidence-based, sort of systematic review style pieces of evidence. And some of these do include dosing guidelines, but they're not obvious to find all the time. Sometimes they're buried within long journal articles. And we've also seen the NHS England commission G-Notes, which is a really valuable tool. It's a just-in-time clinical resource, but it's really an educational sort of CPD-focused tool, not necessarily that quick to just get dosing guidelines, but really to sort of help you to upskill yourself in that area. And when it comes to CPIC and PharmGKB and those sort of international resources, they're very much linked to FDA labels or European drug labels, which don't always align with the UK drug labels. So when we think about the UK-specific resources, we do have quite a lot and increasing numbers. In particular, I've put a screenshot there of the Electronic Medicines Compendium, which is where the UK drug labels are published. Not everybody's familiar with using these. Pharmacists often use these quite frequently, but other healthcare professionals may not use them on a regular basis. And actually, pharmacogenomic information is quite buried in these long, many pages documents, and it's not always in the same place. Obviously, we've talked today about NICE starting to publish guidelines. We know that the MHRA publishes drug safety alerts recommending testing. We've seen NHS England publishing urgent policy statements, and we have the National Genomic Test Directory, which has started to have a suite of pharmacogenomic tests. And none of these are reflected in the international resources that I highlighted. So what are we proposing? Well, we're proposing to create a user-friendly interface to a point-of-use resource in the format of simple drug monographs that provide pharmacogenetic dosing advice that will be referenced from original sources such as the SPCs, CPIC, NICE, MHRA, and the NHS England Genomic Test Directory. We're not going to be writing new clinical guidelines. This is really an interface tool to put things in a simple, easy-to-use format. We envisage that its use might be at the point of prescribing, particularly where there's no clinical decision support in place. We're aware that there is clinical decision support tools being developed, but unfortunately an awful lot of prescribing in the UK still happens non-electronically, often on paper, often without clinical decision support tools in place. But also, and this is particularly important for pharmacists, around retrospective review of medicines that have already been prescribed. And that might be part of medication reviews, but it also might be just after a drug's been prescribed, because pharmacists review prescriptions that have just been made hundreds of thousands of times a day, and part of that process is being able to check that the drug is safe and appropriate for the patient. And we often don't have those clinical decision support tools in front of us because of the interoperability issues. So we've really tried to think about how pharmacists use these kind of tools in a kind of drug monograph format, and in a very similar way to the way that we already use either the Renal Drug Handbook or database, or there is a publication called the UK CPA Handbook of Peri-Op Medicines. And actually, because of that previous publication, we are going to be using the same web platform. So if you'd like to have a look at what that looks like, I've put the QR code up here. So the Handbook of Peri-Op Medicines has been published for a number of years by the UK CPA. And you can see, if you get onto the website, that you can search by drug name, and it's an alphabetical, sort of alphabetical resource by drug names. And if you go into them, they're sort of individual drug monographs. So we'll be using the same format. So what are we planning to include? Well, in the initial publication, this is our inclusion criteria. We will include all UK licensed medicines that have one or more of the following. Our first inclusion criteria is drugs that have UK MHRA licensing that either requires testing to determine the dose or management, or that requires action against a known result. Our second criteria is any drug that has an MHRA drug safety alert that either recommends testing or that recommends action against a known test result. Our third criteria will be any NHS England or Genomic Medicine Service commissioned tests and their associated therapeutic recommendations. Our fourth criteria will be NICE recommendations around testing, and we will include CPIC actionable therapeutic recommendations. But we are aware of some work being undertaken by the UK Pharmacogenomics and Stratified Medicine Network to produce a UK version of guidance which will include that sort of systematic review style, look at all of the evidence and recommendations on who should be tested and what the dosing recommendations will be. And so we expect that as those become available, they will supersede an American version. So if we apply that criteria, we get 93 medicines in version 1, which we think is enough to make it a good resource. There is potential for additional medicines to meet the criteria before publication, possibly if they have a new licence granted by the MHRA, or perhaps a new NHS England test directory application might be approved and a new test might be commissioned. Therapeutic recommendations for classes of drugs will be split into individual drug monographs, and that's reflective of the way that we know that our membership and pharmacists use these kind of resources. So that will be different to things like CPIC, which tend to publish one guideline for all classes of medicines. And I'm not expecting you to be able to read all of this, but just in case you were wondering, this is what the 93 drugs looks like and the associated genes, and you can see that classes of drugs have been split out into individual monographs, so there'd be a separate page for lansoprazole, omeprazole, pantoprazole, rabeprazole. This is just a quick look at what the format will be. So this is an example for siponimod, and the actual clinical detail in these monographs is still to be finalised, but really to sort of look at what we think the resource will look like. So that's quite a simple one. When you're looking at a proton pump inhibitor, it's a little bit more involved, it's a little bit more complex. So how will we do it? Well, the monographs will be written by one of the lead authors within the UK CPA Genomics Committee, and then we're planning that they will each follow a two-step process of review and approval. Step 1 will be a first review by a second author or a member of the committee, and then we will have a process of second review by an independent specialist contributor before publication. We're expecting to publish all our monographs with a publication and review date, although we haven't determined how long that will be. And there is an inbuilt ability to mark monographs as in review if evidence changes, and we can either close the existing monograph if we think there's a safety concern, or you can keep the existing one up with a note to say we're aware that something new's come out and we're working on it. We're planning a series of stakeholder events and focus groups for later this year or early next year, and the stakeholders that we've identified are some of the professional bodies, expert contributors, and we very much hope that people in this room might be willing to be expert contributors. We cannot do this resource without you. And of course the end users, which we expect to be clinical pharmacists, but also medical and non-medical prescribers. These are the professional bodies that we're currently working with. So the British Pharmacological Society, the Royal College of GPs, the Royal Pharmaceutical Society, and the UK PGX and Strat Medicine Network. And we very much hope that these organisations will feel able to endorse the final handbook, but of course until we have the product, we don't know that will be the case. And when will we do it? Well, we've already started work, and we are aiming for publication towards the end of summer next year if we can get all of those 93 monographs finalised. So how can you help? Well, you might have noticed that there are 2 items on the agenda that are very similar. So this session just now is for me to sort of introduce our plans and to invite you to our open stakeholder session today at 4:30. Obviously, I know that some of you need to get to faraway places and may not be able to stay. So that's part of the reason why I wanted to share what we were doing earlier. But later today, we'll have a bit more time to get into some groups and get some feedback from you as experts on the work that we're doing, have a little bit of a closer look at our inclusion and exclusion criteria. Thank you.
Thank you, Lucy. That's great. Any quick questions or immediate thoughts? Yeah, Jackie here. Oh, just behind you, and then we'll go over there. No, it's okay, because then people at the back can't.
I can't stay for later, but I just did wonder whether or not you would issue out license to companies to be able to use your database as part of their infrastructure for guidance when they're developing solutions. So one of the things that we're trying to do with the industry work programme is get consistency, get reliability amongst the data that's being pushed out from commercial organisations. And it seems that if this is something that's going to coordinate with the work that the PGX network are doing as well, then it would make sense that if you're able to...
You won't need a licence. It's going to be an open access resource.
You didn't list industry as members, so I just thought I'd double...
Oh, I see. You mean as stakeholders?
Yeah.
yeah, so we can chat about that.
Great, thank you. There's quite a few questions. There's a couple at the back, and I think one in the middle just there. You've got a microphone already. Great.
Sorry, it was just a quick one because I also can't stay later. You mentioned that while the UK is creating their own guidelines through the Stratified Medicine Network, that you were referencing the CPIC guidelines. Now, obviously, there's also the Dutch ones, and sometimes they do have different recommendations. What was the rationale for picking the CPIC ones?
Actually, I don't think there's a particular rationale, and that's definitely something that we probably need to go back and include, which is why we're trying to socialise the idea today to find out what we've missed. So thank you. I think I'll take that back and have a look.
Okay, I think there's some questions right at the back. We'll just let Barbara take the microphone. Great, thank you.
Hi, Lucy. It's not a question, it's more a comment. I know Macmillan are looking to do some work in pharmacogenomics in the cancer sphere, and I just wonder whether, as one of your stakeholders, if you're linking in with them, because from the discussion they had with me literally earlier on this week, a lot of what you've just described, they sound like they're probably looking to do as well. And I just wonder whether there's a bit of
So if their members are likely to use the resource, then yes, I think they could be a stakeholder. So I'll come and chat to you.
Okay, thank
in
you.
the break.
Thanks.
Yeah, Veneer.
Thanks, Lucy. This is really exciting. So, quick question. Have you had a chance to discuss with the British National Formulary Committee and with consideration of whether either in the first instance or at a later date they might be able to cross-link between the resources directly to aid physicians and non-medical prescribers at the point of the prescription?
Yes, we have met with the BNF, but at the moment the UK CPA wants to keep the resource as their own. Of course, that could be a revisited discussion in the future.
And Veneer.
I just want to highlight a specific issue, if that's okay. So I realise why you've done this. You showed the Siponimod monograph there, and it has star 2, star 3. That's because that's what's in the SPC as well. But actually, multiple sclerosis is common in people of African background as well, and they won't have star 2, star 3, they'll have star 5, star 8, star 11. And I've talked to a lot of decision support systems in the United States, and they've changed the guidelines. And I also act as an editor for medical genetic summaries, and they changed the guidelines as well. So they've now got star 5, star 8, star 11 in there. So I think if you do that, although you're following the SPCs, it is important to consider the diversity, which is not covered in the SPCs.
Yeah, that is a really important point, and I think that might be where we need the guidelines from because we're not going to write the original guidance because we're not able to do that. So we're going to have to be a one-stop shop for what already exists. So I think that might be something that we'll need to keep an eye on the other producers of the original resources and hope that it gets included in there. I mean, it's going to be an evolving process. So this will be first edition, and there will be limitations, and that may be one of them. But as we go forward, we hope that we'll be able to keep up with how things change.
But since you're starting, you might want to change the Siponimod now.
Yeah.
Can I ask Veneer, I mean, I think it's fantastic what you've done there. We engage with CPIC around Siponimod just exactly on the basis that you've described, that it doesn't cover all those views. Have you got any sense that CPIC are going to do anything in that space?
CPIC, I don't know about CPIC. I haven't engaged with them, but the medical genetic summaries, which often follow CPIC, where I'm one of the 4 editors, I got them to change it.
Yeah, great.
So Siponimod for the medical genetic summary has been changed, and I then talked to several decision support systems in the United States, and they've also changed it.
Yeah, it's interesting too, because there are so many different players working out how you get in and affect change. And one of the things, CPIC are a great resource, but they only update sort of 3-4 guidelines every year or so, even then, and it takes so much time and energy to change things, so it's difficult. Okay, thank you very much, Lucy. I hope as many of you as possible can stay at 4:30 for the open session, which would be great. I'm going to ask you, rather than come back at 4 o'clock, to come back at 4:15, if that's okay. Gives you a little bit more time just to have a coffee, just relax and follow on those conversations from lunchtime. So thank you to Lucy, to Videha, to Wout for those really fantastic presentations. So all I wanted to do was just highlight a couple of things. Firstly, to say thank you so much for your engagement, your efforts, and your conversation and your thinking today, which has been really great. To all the speakers, the facilitators, and all the support staff. So lots of people have put in, as you can imagine, lots of effort into organising today, but particularly Barbara, who has, always goes that extra mile to make sure that everything's all sorted. So thank you to her, but also to the rest of the team as part of the Network of Excellence. It's great to see our progress team here who have put so much effort into all the recruitment and organising everything and getting everything sorted. So thank you to all of them as well. I started at the beginning by mentioning a couple of things that we very much want this network to be seen as completely collaborative, as a forum in which people can share ideas, in which we can stimulate conversation, and it be a very supportive environment where there are people with lots of different skills here, lots of different backgrounds. Unfortunately, we didn't have any stroke physicians or any oncologists, but we had lots of other people here. But actually, we, as a group, need to reach out across all our colleagues. It was really great to hear from Mark at the beginning of the day, and a number of times comments through the course today, recognising how that patient voice and the public dimension around this to use that, but also to hear that and to make sure that that really drives forward our thinking and our programme of work. Emma and the team are putting together plans and we'll be coordinating those for our next Network of Excellence event, which will be in the spring. We've got lots of ideas. A couple of people have come up to me today and mentioned different things they'd like us to focus on. If you've got ideas, do send them to us, to a member of the team. We're constantly updating our website, and some of the resources from today will be available. That will all take a little while, but if you've got questions that you didn't have an opportunity to ask today, or you're travelling back, or over the next few days you think, oh gosh, I should have asked that, or I wonder how that's relevant, do get in touch with us. We're really keen to talk to you. And we're not wanting to take over people's projects. I must reiterate, we don't want to lead every single project, but we're really interested in what other people are doing. It's only when we understand what other groups are doing, what their interests are, what they're trying to promote, that we can have sight of that, but also we can support it where it's possible and where we can. And certainly from the workshops and from other conversations, this is a really dynamic area. There are some areas that have been underinvested in, or some areas of pharmacogenetics where there's opportunity to make more progress. And it would be really good to think that we can highlight those, and either through funding, through NIHR, or one of those routes, or alternatively through more funding from a future Network of Excellence, to start to crystallise our thinking about what it is we want to do, where we can have a really big impact, and what allows us to really make sure that pharmacogenetics is implemented in routine clinical medicine. But I know that a number of the pharmacists and a number of the other people in the room will absolutely push the message that pharmacogenetics is only one element of good medical prescribing. It's about all those other things we heard Munir flagging earlier about how important understanding about adherence is, making sure people are on the right medication, making sure that we understand more about drug-drug interactions, comorbidities, all of these elements, and really folding pharmacogenetics into that as another tool in our armamentarium. So I'm going to stop. I talk too much. You've had enough of me. It's very nice to be able to hand over and allow the final session for Lucy to progress things and to build upon what she said earlier. So thank you so much for coming today, and do keep in touch with us all. Lucy.